Thank you. I am very fortunate that Benchi Sabu is chairing this session. Thanks to Manoj and Puri for giving me this opportunity once again to speak on obesity, and that to our after the barrier, the physician of India, Makarsa. So I don't know, my slides are appearing as a PDF and not as PowerPoint slides. I don't know why. I will give it, yeah. So these are some of the pictures from Kerala. So this is an Aero Symposium, and we are super active in Kerala. Dr. Benshi and Dr. Makar always used to make such comments. We do programs for the public. We do obesity awareness programs for children in schools, and we do physical as well as online CME for doctors. And this is the necessity of the hour. And of course, this is a dream for all of us, to be physically fit, to be mentally fit. And that is not that easy. To maintain the ideal body weight is extremely difficult. To lose weight is of course difficult, but to maintain the ideal weight is much more difficult. And there are multiple ways of doing it. And for many, many years, and this is a 2009 publication in Lancet. Look at the association. Of course, this is nothing new, but this association is very important. With increasing BMI, there is a significant reduction in the life expectancy. So we live shorter with a higher BMI. If the BMI is normal, of course, these numbers are old numbers. If the BMI is normal, there is an 80% chance of reaching the age of 70 years. And if the BMI is above 40, then the chance is only 50%. It is reduced. So there is only 50% chance of reaching the age of 70 if your BMI is 40 or above. So that means there is a reason for we as doctors to advise our patients to reduce the body weight, and if possible to measure the body composition analysis, and to make sure that we are assisting them to reach their ideal goal. And in our clinics, we routinely discuss the 4 M's of obesity, which are so important. So important, and this is important in making our people with obesity aware of their, so they will start relating to their own illnesses. So when we discuss about depression, anxiety, or osteoarthritis, or treating more than 300 complications of obesity, the monetary reasons for why they should be treating or controlling their obesity, the metabolic complications, especially the obesity related cancers, many of them will start relating these illnesses to their own obesity or obesity of their own family members. And this is also worth discussing. Why not treat obesity only with diet and exercise? Only with diet and exercise. So my topic which is given is future, and the future of chronic obesity care. And this trial is extremely significant. The Look Ahead clinical trial, which was conducted in multiple centers in the United States. And this was in people with diabetes, with overweight and obese, and a total of 5,000 subjects. And this is one answer I give to my patients when they argue with me that, doctor, I don't want any medications. I will treat my obesity with diet and exercise. Give me 3 to 6 months. And they could have already tried multiple years, many years for treating their own obesity. But here, if you look at the 2 arms of this study, only with diet and exercise, one is intensive lifestyle modifications, and the other arm is only education support. And the primary objective was to look at the number of events, the event rates. And the study was meant for 13.6 years. And I know that all of you are familiar with the Look Ahead trial, but whatever I am discussing is something which is not usually discussed. People lost their weight, and of course they regained their weight after some time. The glucose got reduced, and sometimes diabetes can go for a remission. The blood pressure medications necessity will also come down. So many good things happen. But the trial was stopped at 9.6 years because the event rates were similar in both the arms. So this is something which is shocking. With diet, exercise, lifestyle modifications, when somebody is reducing the body weight and compared to the other cohort, no differences were there. And this was the major adverse cardiovascular events being assessed: CV death, non-fatal MI, non-fatal stroke, and then heart failure, then angina, they found that it is the same. So this is a signal, this is a danger signal. Intensive lifestyle intervention produced greater reductions in the A1C. And this trial, which is focusing on weight loss, did not reduce the cardiovascular events in overweight or obese people with type 2 diabetes. So our quest for medications probably started there. But we didn't have any effective, safe medications until very recently. It's only maybe 9 years ago we started having safe medications for treating obesity as a disease. And again, for those who are arguing, with lifestyle modifications, we can lose on an average only 2.6% body weight. And this is again data from the step clinical trials with injectable semaglutide. But with drug, you can lose 15% or 20% or 25% or even more. So you require pharmacotherapy. Of course, I don't agree with this, but you have to add on to the existing lifestyle modifications, the pharmacotherapy, the safe pharmacotherapy. So GLP-1, they have been around for more than 18, 19 years. When people discuss about GI side effects, stomach paralysis, the news which is appearing in the media on multiple other adverse events, this is the answer. This is not a new class. This class has been around for more than 19 years, exenatide, liraglutide, and now we have the wealth of evidence from the STEP clinical trials with injectable semaglutide, substantial reduction in the overall body weight, and addressing not only homeostatic but also hedonic hunger, and this is important. So these are the class of drugs which can address not only the homeostatic hunger but also the hedonic hunger, that is the hunger which is secondary to the sight, smell, the sound of food. So you get attracted to a lot of environmental signals. And even without any caloric requirement, even when you are not hungry, you are bound to eat more and more and more. And that is also controlled with injectable semaglutide. And then, of course, another blockbuster drug globally, tirzepatide, the dual agonist, the dual incretin, and strongly supported by SURPASS and SURMOUNT clinical trials. SURMOUNT CVOT is also published, and that has also been established. CV safety is also established with tirzepatide. So now the goals are expanding. So look at this data, and this is on secretion and main actions of the gut hormones. So this, you have glucagon from the alpha cell, and then the peptide YY and GLP-1 from the L cells. These are basics. And then you have the long list of old and the newer drugs, GLP, GIP, then glucagon, which increases the energy expenditure. But something which is common for all of these gut hormones, but which is similar to is suppression of the appetite. So it acts via the hypothalamus, the arcuate nucleus, and it suppresses the appetite. And then you have the increase in energy expenditure with amylin and peptide YY as well. And then you have the upcoming triple agonist. So we are also, as principal investigators, many of us are involved in the development of this molecule as well, and this is retatrutide, which in addition to GAP and GLP-1, there is also a glucagon receptor agonism. So the pipeline is very strong, and this is what we have learned, the truth that we have learned. And this is the difference. This is also some data which is not usually discussed. There is a difference between weight loss in people with diabetes and without diabetes. So this is a 3 to 5% difference. So when you are using the same class of drugs, starting from liraglutide or even oral or the injectable once weekly preparations, the weight loss is substantially more in people without diabetes. And with diabetes, for reasons known to many of you, it is 3 to 5% less. And this is the data of the existing drugs and in the pipeline. But tirzepatide, it is 22.5, and with retatrutide, it can be even more than 24% weight loss. And this is that history of evolution. So when you are considering the diet and lifestyles and some of these surgical techniques, are they getting replaced? That is a big question. Are they getting replaced by these medical therapies? Of course not, but to an extent, for example, sleeve gastrectomy, or to an extent, a part of gastric bypass surgeries, up to 25 or sometimes even 26% weight loss is now possible, which has once been only a dream. But now it is possible with these newer therapies. It is possible. So look at the drugs in the pipeline. You have cagrilintide, you have masdutide, you have survodutide. So all of these are promising therapies. And if you look at all these drugs uniformly, the weight loss for almost all of them is more than 10%. And many people, many of our patients actually require only around 10% weight loss. And that is the truth. And these are the limitations. Of course, we should be discussing. So why should I be discussing about the future? Why should I be discussing about the chronic weight management? Because there are challenges. Number one challenge, discontinuation because of side effects. And there is an entity called non-responders. And these non-responders were more with the earlier drugs. And the new drugs also, 20 to 30% people will not have any weight reduction at all. They might have other advantages of the drug, but there won't be any weight reduction. And we need newer drugs to address this. So this is GIP as the backbone, the pipeline for gut hormone-based anti-obesity medications. You have GLP. These are the upcoming therapies. The phase 2 clinical trials, some are phase 3 clinical trials. Semaglutide is now tested in phase 3 at 7.2 milligrams. So currently in India, we are using up to 2.4 milligrams. And oral semaglutide, Rybelsus, the generation 2 will be 50 milligrams, supported by Viasis clinical trials. Oral one, orforglipron from Eli Lilly. And these are the dual agonists, Kesavadev, already there in the market. And there are multiple newer agents and a GIP agonist. And then you have amylin agonist, that is cagrilintide, long-acting amylin agonist from Lilly family, PYY agonist alone or in combination with semaglutide from Novo Nordisk. And then GLP-1, GIP, that's a triple agonist. GLP along with glucagon agonism, and that is survodutide and many other. And even a mono agonist for glucagon also is being tested in a phase 1 clinical trial. There is a tetraagonist. And these are all the newer agonists for a particular reason. And if you look at the tetraagonist, it's a combination of amylin, GLP, GIP, and calcitonin. The reason being calcitonin has counterprotective and anti-resorptive properties. We are concerned about bone loss. We are concerned about lean muscle loss. So whenever there is a weight reduction, 30% plus or minus 15% weight loss is attributable to the lean muscle mass. So moving on to the question, are they sufficient? Diet, exercise, and pharmacotherapy. Are they sufficient for maintaining the lost body weight? And the answer is, you will require technologies to support. Similar to in diabetes, you will require technologies to support weight loss as well as to maintain the lost weight. And these are the wearable technologies, broadly defined as electronic device worn as a private accessory, of which smart rings are extremely commonly used in India. Smart glasses are also widely popular globally, and many others are coming up. And this is smart fabric, the textile with sensors woven into the textile, gradually evolving and becoming very, very common. And it can collect the biometric information such as the heart rate, the temperature, the breathing, the stress, movement, the acceleration, and even the hormone levels. And then smart scales. So we have been using smart scales for more than 15 years now in a connected environment in the clinics, or it can be even in the houses of our own patients. Sleep is important. In weight maintenance and in weight reduction, don't forget about sleep. And sleep, if possible, need to be measured. And with Apple Watch or with Samsung and with the wearable devices, now we can precisely measure. Less than 6 hours is associated with higher BMI. A sleep more than 9 hours, because it is a U-shaped association, is also linked to obesity and many other illnesses. And these are some of the devices which can measure precisely the duration spent in each component of the sleep and so on. And if you are interested in Apple Watch, this is a pretty old video. It is still there in YouTube. And for a beginner, I promise it will be extremely beneficial. There are more than 100 parameters which can be measured. And this describes, Apple Watch is described as a future of health on your wrist. And this is launched at Libre 2 Plus. Dr. Benshi, Dr. Manoj, Urvi, Dr. Makkar sir, Dr. Sanjay, I spotted you only now. So Dr. Sanjay, you can see all our friends there launching the Libre 2 Plus in India at the recent July 12th JPF. Dr. Tade is launching Libre 2 Plus. And this is probably one of the most accurate, reliable continuous glucose sensors in the world, Libre 2 Plus, with a very low mark of 8.2%, including in the hyperglycemic range, real time, no requirement of scanning, no data caps, and lasts for not 14 days but 15 days, and the data is stored in the cloud, and there is an option for remote monitoring as well. And can CGM be used for weight management? And this is a very recent advancement in the August of 2025, the first ever CGM which is US FDA approved for weight loss and metabolic wellness. And this is from the Dexcom family, Stilo, and it connects to a mobile app, AI-powered mobile app, real-time insights into how food, stress, activities, sleep can affect the glucose levels and multiple other metabolic parameters. Remember, CGM system which is approved for weight loss by US FDA. So this has been already proven in multiple clinical trials along with personalized nutrition. If you are on a continuous glucose monitoring, of course, with the aid of a mobile health application, people lost almost double the weight compared to those not on a continuous glucose monitoring device. And there are statistically significant benefits when you are managing obesity with the help of a continuous glucose monitoring system. So here, these are the concluding remarks. Successful weight maintenance, and that is chronic management of obesity, will require, in addition to diet, exercise, and drugs, smart pairing with the so-called wearable devices that I have discussed. And once again, this is my responsibility to invite all of you, and this is our own conference, the RSSDI, one of the biggest events in India. And welcome to God's own country. The RSSDI president is sitting over here. RSSDI secretary is sitting over there, Dr. Sanjay. So on behalf of all of us, RSSDI members and executive committee members, I invite all of you to the city of Kochi at Grand Hyatt in the month of November. So thank you very much, dear friends, for your patient hearing.